Hey everybody, welcome back to the UWorld Live NCLEX review series. We are so excited you're joining us today on our sixth and final live of the summer. And today's a very fun edition of Viewer's Choice. So we did an Instagram sticker a couple times, got your responses, and that's what we are doing today. So for those of you who are new here, my name is Holly. I am a nursing content developer here at UWorld. I also work in the CVICU, PRN, and I use UWorld to prep for my NCLEX. I'm joined again by Andrew. You may remember him from a couple of weeks ago.
That's right. Hello everyone. Those of you that this is your first time, I'm Andrew. I'm a med-surg nurse, been a med-surg nurse for about 4 years. I'm a nurse content developer here at UWorld, and I also use UWorld to study for my NCLEX. Yeah.
Awesome. So just as a reminder, please don't forget to set your video quality to at least 720p. We've got a lot of text on the screen and we want to make sure you can see it.
Absolutely. And something else, anytime you have a question or a comment or something, feel free to use the chat function. That's what it's there for. We do have some folks, some moderators who are able to respond, and we'll hopefully be able to answer some of those questions throughout the session today, as well as the end. So any nursing style questions, UWorld questions, whatever you have for us, we'll do our best to answer those throughout and at the end of the session today.
Yeah. So today, Andrew and I are both going to be presenting. We've got 2 questions each. You guys had some great responses, so we tried to weave in as many of those as we could. But before we get into that, though, we did have a lot of requests for next generation items. So.
Absolutely. And while Next Gen isn't coming until April of 2023, for some of you, you might find it beneficial as a study resource, especially since a lot of these case studies that are going to be Next Gen cover topics very much in depth. Now, some of the question styles are different than what you would expect before the switch in April 2023, but might be something you might be interested in. So we're actually going to take a look at that and how to reach a Next Gen item on our demo on UWorld's website. So if we could go ahead, we're going to take a look at that.
So we're not going to go through the demo item. We just want to just show you guys that it is here so you guys can look at it yourself. But we will be in the fall doing a lot of NGN content, so we want to make sure you know about that. So if you go to the UWorld website here and you scroll down to nursing, click Get Started. And when you get to NCLEX-RN over here, you see this little yellow View Demo button. And so this is great because you get to basically look through some UWorld questions, see the platform, get a feel for everything without putting in any sort of information, credit card, anything like that. So when we click View Demo here, it's going to take us into what looks like the QBank. Of course, we see demo. And so we're going to do all of the items. Now, if you're looking for this case study, you want to go back and do it yourself later. It is going to be towards the end. So I'll show you here. So we're going to generate. And once we're in here, we've got 25 regular items. And then we also have a case study. And a case study is going to be 6 items. And that's the standard that the NCLEX-PN, who creates the NCLEX, has set forth. So when we get into item 26 here, you can see this looks a little different than you may remember any other question before. But these 6 questions all go together and all kind of build on one another. And we'll get into that a lot more when we start doing NGN in the fall. But we just want you guys to see. So here's part of it, another part, and we just keep building and going and all of that. And so this can be a really great one to look at. And like Andrew said, if you're trying to get really get some solid subject matter, kind of get some knowledge down about something, a diagnosis, a medication, whatever, these case studies can be really great for getting that well-rounded knowledge, and not just little pieces here and there, but really getting all of it. So we just want to show you guys this, and again, the demo is free. There are, if you keep looking, there are some other options here, or other different items that you can go through. And like I said, we have made sure that our case studies and other next generation items really mimic the information that the NCLEX-PN has put out about the next generation NCLEX. So that way you guys can have the most accurate and most similar to what the test is going to look like, so it's not so foreign to you.
Yep, absolutely. And we have currently we have case studies in our RN test bank. We're working on getting case studies to our PN test bank as well. So, yeah. And
then we've got more to come, just next gen wise, and both banks, learning platform, all of that. As time goes on, we've got a lot of stuff in development, and it'll be really great for you guys.
Yeah.
So.
All right. So
we're going to go ahead and get into our first item now.
Let's do it.
So, first up here, we are going to be looking at question about Kawasaki disease. And so you guys were asking about prioritization, you were asking for pediatrics, and you're going to get that as well in both of those. So looking at our STEM here, we've got a child who is receiving treatment for Kawasaki disease in the form of IV immunoglobulin. And we're trying to determine what action we need to have as our priority. So, little tip, when we are looking at priority questions, this can be a little wordy, but I think you'll see exactly what I'm saying here. On your whiteboard, you can write, or just in your head, rephrasing, in relation to this diagnosis, this medication, whatever it is, which of these actions are going to be the most beneficial for me in terms of maintaining ABCs, maintaining safety, and preventing further illness or injury. Oh, well, let's restart our little test here.
So we do, if y'all notice, we do have the poll up. We're going to get back into that question here shortly. So when we do have that back, we're going to talk a little bit more about answering these priority-based questions. But feel free when we do have it back up, which we have it up now. Mm-hmm. Go ahead and put your answers in as far as what would you like to see. So go ahead.
So options here, we've got cold compress to hands and feet, monitoring for Gallop heart sounds, and decrease urine output. Maintaining a quiet, non-stimulating environment, and providing soft foods and clear liquids. So we'll let you guys go ahead and vote. All right, and it looks like most of you are selecting option 2. So let's go with that. All right, so good job, we were correct. So I'm gonna come back to this image in just a second here. It's a great visual for Kawasaki disease, but I want to kind of get into a little more of why that's happening before I tell you too much about it. So, in Kawasaki disease, we have an inflammatory condition, and it's usually an unknown origin, and it causes inflammation of blood vessels in children. So the condition is especially dangerous because these small coronary arteries, which we'll see up here, are very susceptible to injury, and all of that swelling can cause an acute issue in regards to, let me see if I can get this anymore. I think we'll just stay here. It can cause, acutely, it can cause coronary artery aneurysms, as you see here. And left untreated, these can expand and eventually burst and obviously cause a whole host of issues. Additionally, it can cause the chronic issue of heart failure because all the fluid is backing up, the heart pump is ineffective, and that can just cause a lot of long-term issues. So with Kawasaki disease, we also can have high fevers that are not responsive to medications, conjunctivitis. We have strawberry tongue here, as we've seen before, which literally looks just like strawberry, so works out. Swollen and cracked lips related to mucositis, and then erythema of hands and feet with skin peeling, so we'll have the desquamation. And all of those are just because that fluid is just not able to be excreted, but also, we'll talk about in a second, this medication is going to be kind of pushing it out into the space. And so when we're looking here back at the image, just really quickly show you how all that manifests. So because we've got the inflammation and everything, we've got the fever, we've got lymph node swelling, we've got the conjunctivitis, the mucositis, and so we're going to have the swollen mouth, tongue, lips. We're going to have swelling with hands and feet, really extremities in general, and because of that swelling and that pressure on the skin, we're going to have some of the desquamation and the skin tearing and all that. And then, of course, the major risk with the heart here of those coronary artery aneurysms. And so when we're looking through our treatments here, our correct answer was option 2, which was looking for the Gallop heart sounds and watching urine output, because the IV immunoglobulin that we give is going to increase the plasma oncotic pressure, which basically means it's going to pull fluid into the intravascular space, and that's going to lead to fluid overload. So we're taking it out of the cells and into the vascular space, and we're going to have a lot of swelling because it's a lot of fluid being pulled out, and it can be kind of hard for the kidneys to keep up. So you'll see here we also give aspirin. Now you may be like, I was told we don't give aspirin in kids, which is true with the exception of Kawasaki disease pretty much. And that is because the benefits outweigh the risks in terms of the development of Ray's syndrome, and also Kawasaki disease isn't necessarily related to viruses, whereas a lot of times with Ray's syndrome and aspirin, there is a virus at play as well. So we do want you to be aware of Ray's syndrome. Just so you know, the biggest thing and why we don't normally give the aspirin to children is because you've got a risk of swelling on the brain as well as liver failure. And obviously these can cause long-term chronic issues, and if not resolved, swelling on the brain can even cause death in the immediate. And so big thing here is we're going to look for the signs of heart failure because of all this fluid retention related to the IVIG. And we're also going to be, or with that, we're going to watch for decreased urine output because that's a sign. It's a sign, that the fluid's just hanging out inside. And we're also going to be looking for gallop heart sounds. So this, great way to see, we talk about S1 and S2, which are your lub and your dub with your cardiac cycle. But sometimes you can have extra sounds, so a third or a fourth. And if we look here, you might see how it says children normal. And it can be, but it's important to note that if it was not present in the child prior to this diagnosis, that it would, if it's different, if it's new, we obviously are going to be concerned about that. But also you need to know that it is associated with heart failure here. And so the biggest thing is knowing if this is a new third heart sound and the client is experiencing all these other symptoms of Kawasaki disease, that we are potentially getting into heart failure territory. So I want to play a little audio real quick for you guys of what that S3 sounds like, because we can talk about it all day, but to hear it is actually going to be more helpful. So it's only a couple seconds long, so I'll play it a couple times for you guys here. And one more time.
All right.
So, looking at all that now, we can look at our incorrect options. So we had option 1 of cool compresses to apply, and then option 3 was providing soft foods and clear liquids, and option 4, which was providing the non-stimulating quiet environment. While we definitely want to do all of these things, this question was asking for the priority. So which one of these is directly going to affect our client's safety, going to affect our perfusion, all of those things. And so obviously we want to do these things. We want to make sure if they're having any swelling that we have simple foods provide our easy to swallow things, so that way we're not running the risk of aspiration or anything like that. And we want them to be comfortable as much as we can, because these children unfortunately are going to be fairly inconsolable sometimes. And so promoting that quiet environment, cool compresses to help with pain, all of those are great, but they're just not going to be our priority one. So again on here, and if you guys have any questions, go ahead and start leaving them for us. Just reviewing our educational objective, which is our little bit of a summary here. IV immunoglobulin, or IVIG as you may hear it called, is used for Kawasaki disease because it helps reduce inflammation and prevent coronary artery aneurysm. It increases plasma oncotic pressure, and that can lead to fluid overload. So we need to make sure we are monitoring for signs of heart failure. And our specifics here were decreased urine output and the gallop heart sounds. So if you look at our client need category, which this is how the NCLEX-PN separates out things on the NCLEX, falls under reduction of risk potential.
Fantastic. So someone like myself, I'm not very well versed in pediatrics anymore at this point. I'm adult med surg, right?
Yeah.
And some folks may not have as much understanding when it comes to pediatrics, especially when they're studying for the NCLEX. So let's say I don't know what Kawasaki disease is. Like, what would be, like, if I'm sitting there and like my mind goes blank on the NCLEX exam, like what should I do in regard to like this question, and like what should I really be thinking about?
That's a great question. So if we're looking at an item like this and you say, I have no idea what immunoglobulin is, I have no idea what Kawasaki disease is, stop and look at your answer choices. We want to see here which of these options are going to have the most effect on our client in terms of physiology. And so we like comfort measures, but if we look at option 2, it is the only one that is going to have a direct effect, by us monitoring and potentially intervening. It's the only one that's going to have a direct effect on what is going on inside with the client. So, cool compresses, we could potentially help lower temperature and things. The non-stimulating environment can help them in terms of relaxing. And like I said, we don't want to have anybody aspirating on anything, but these are not going to prevent what a big issue is. And our big issue here, like you said, you may not know that it's going to be this coronary artery aneurysm, but we can at least associate this with something big going on in the body. And especially something I've always looked for is when I see decreased urine output, I know that tells me we have a perfusion issue. And so we talk about airway breathing and circulation. That's circulation right there. If our volume is altered, we're not circulating like we're supposed to, and that's going to affect other things. So just always look for, out of your options, which are going to cause the most effect in terms of the client's general, well-being, health, what's going to prevent further issues in this case. So
awesome.
That's a great question.
No, definitely. That was great. I do see a question, or we have one about select all that applies. We do have 2 items today that are select all that applies, and so
we'll try to load you up with some tips in there.
Definitely. So if there aren't any further items or questions, anything else on Kawasaki
It looks like
disease?
that's all we have for right now, but if you guys come up with something else at the end, we can definitely answer those towards the end. Yeah.
Okay.
So we're gonna go ahead. Andrew's got this question now, so I'll let him take over.
Fantastic. So we're kind of staying with pediatrics. Another item or item type that was requested had to do with growth and development. And so while there's different things that you can talk about growth and development wise, especially when it comes to cognitive development, physical development, psychosocial development, most of it is going to be very kind of a lot of it has to do with memorization of facts.
Yep.
And kind of really getting into understanding, or at least knowing, like what you would expect, and then you building that foundation of those early facts that you need kind of need to have as a basis can really help you answer these questions moving forward. So just kind of a general test taking tip when it comes to some of these development questions, any kind of flashcards or highlighting or anything like that might be beneficial for you, whatever you feel is best. That's the direction I would take first.
Yeah.
Really get that solid foundation of, what facts you may need to know first. That's really going to help you answer some of these questions moving forward. So, taking a look at this item, we have a 6-month-old infant, and we're looking at expected developmental findings. So, we can't do a poll for this item, but if y'all want to go ahead and leave, which numbers you think are correct in the comments, we can take a look at that after we address each one of these items. So a couple of tips, and somebody asked when it comes to select all that applies. I know our other Holly, she's mentioned starting at the bottom first and working your way up through each answer choice. That kind of helps slow you down, helps you take a deep breath, makes you kind of rethink how you're going to look at the question. So that's one option for some folks who choose to do that. Another big thing is, and we've said this a few times, is take a look at each answer choice, and really you're honestly answering it like a true or false, essentially. So is this answer choice true or false for a 6-month-old infant with, as far as an expected developmental finding? So I'm not sure if y'all had started to answer, but I'll give y'all a little bit longer to do so in the comments. When it comes to developmental findings, developmental milestones, if this is a 6-month-old infant, we're going to be expecting that things that would have happened at 4 months are also going to be present with a 6-month-old infant, right? We're not, if we were to lose something that should have occurred around the 4-month, 2-month mark, then that might be something that we need to take a closer look at. So again, these are expected findings. This is what the STEM is asking. So how are we doing on answer choices? Looks like we've got a few.
Seeing a pretty big combination of options here.
Okay.
It looks like.
What's our winner here?
Looks like I'm seeing 2, 3, 4, and 5.
Cool.
Most.
Stick with those. I know there's a few of you selecting one, so let's see what we've got here. Okay. 2, 3, 4, and 5 are correct. So before we get into the explanations for these, let's take a look at our, I hope I can fit this whole chart in here. It's a lovely chart. Okay, so at least with our question bank or whatever book you're using, whatever resource material you're using, there's going to be some type of either a table or section that's going to essentially list these items for you, right? Or these developmental milestones: gross motor skills, fine motor skills, language, social cognitive development. So I'm looking at this and I'm thinking, hey, this would be great for like note cards, flashcards, what have you. So something for myself, or something that I would think would be very beneficial, is if I started taking some of these items and like maybe splitting it up by the age, right? Something that's very important that you need to know with the NCLEX is these age ranges are an average. It's not that these developmental milestones are going to occur right then and there at that age. It's an average. Some infants can hit these milestones sooner. Some might hit them a little bit later. So it is an average, which means that when you are sitting for the NCLEX, it's not an expectation that you're going to need to know exactly what's happening at this point in time. It's an average as far as the age. They're not going to try and trick you as far as giving you a specific age and being like, you know, what is this, this, and this? It is an average.
Yeah.
So,
in the same way, I think a couple weeks ago we went through an insulin question, and it was asking about, I think, the time that the insulin peaked. You know, NCLEX knows that you are going to have a lot of things that can have overlap, and that's with, you know, insulin, that's with growth and development, that's with all of it here. That, you know, we can have the overlap, and so they're not going to give you something that is going to be where you could go, well, it could be this, could be that. You know, they're going to make sure that it is straightforward, because they're simply trying to see if you know the information.
Definitely. So let's say I wanted to make a flashcard of this, and this is just something, this is, again, one of our features with UWorld. I want to create a new one with this information. And I guess, yeah, just depending on how I want to create it, you know, I can take this, and maybe I just want to focus on, you know, age of 2 months, 2 month, let's see. 2 months, let's see, developmental milestones. Right there. And so then now I have my flashcard, the front of it, and the back of it's got all of the things that I would expect or suspect. And I could go through each one of these and create that. And then when I go back later and want to review it, you know, I have it there for me. So, yeah. So, again, things that we would expect with a 6-month-old. And a lot of this is just based off of what we have as far as, you know, the average information of what we would expect. So maintaining head control when pulled from a supine to a sitting position. That's something that we're going to start seeing around 4 months of age. Should definitely, hopefully be seeing by about 6 months. One of the things that may need to be, you know, questioned or looked at a little bit further would be any signs of neurological delay, especially when it comes to cerebral palsy. Yeah. So if the child is being pulled to a seated position and the head is lagging, that might be a concern, something we want to look at for, you know, it may not be a concern. It may be something that, you know, we may just need to address with the family or the healthcare provider, whoever it might be. But, you know, as far as things that we would expect by 6 months, lack of head lag would be one of them.
Absolutely.
Recognizing and smiling at familiar faces usually occurs around 4 months. Again, it's an average. Rolling from prone to a supine position, that is 6 months as well. Also, the opposite is true, from a supine to a prone. Either one really should be pretty close to that 6 month range. And then using the elbows and forearms to push up from a prone position. Again, all of these things we're looking at for the 6 months. And even though head control really should be seen close to 4 months of age, it should still be expected to be seen at 6 months.
Yeah, and our question wasn't just asking what are the 6 month ones. It wants to know when they are 6 months, what should they be doing. So that needs to encompass, like you said, everything from birth until now. So don't just pick, you know, the one that goes with 6 months exactly. Absolutely.
So our incorrect option, it was talking about let's go up to this right here, holds and manipulates objects with a fine pincer grasp. That is something that's going to take a little bit more time as far as an average developmental cycle. With a 6 month old, we're expecting kind of a palmar grasp.
Yeah.
And that's more of a gross motor skill. Yeah. That fine motor skill is going to develop a little bit later on. One of the tips or tricks that you can use to kind of remember the fine pincer grasp, which if you know what that is, it's the thumb and the forefinger together. If you kind of want to think of something that might help you remember around what developmental stage or age that should occur, if you take that forefinger and roll it up the thumb right there, it gives you the number 9. So around 9 months, 9 to 10 months, it would be the average for that development of that fine pincer grasp. So is there any questions about developmental stages? Again, most of this is very factual based kind of memorization. If you get that foundation of, you know, what you should be memorizing early on with these types of items, it should be pretty straightforward. That also goes for the psychosocial aspects as well. And
a couple of quick things to add, you know, on these, if you can understand kind of how, like with this one, they wouldn't be at the pincer grasp yet, that you have to have that palmar first. Just kind of taking it, you know, breaking it down in the logical of, you know, if they're not able to complete this more detailed fine task, they might probably, you know, if they can't do the crude one, they probably can't do the fine one yet. And so we need to make sure we're thinking of the logical order of things. Also, if you could scroll down just a little, I wanted to point out on our table here, Just this year in 2022, the CDC, as well or in accordance with the American Academy of Pediatrics and the Canadian Pediatric Society, did do a pretty big update of developmental milestones. And so make sure that if you may have already gotten through pediatrics and nursing school, make sure you review these, just because there has been some changes in terms of what our guidelines are, and we want to make sure you know the most correct and up-to-date information.
Absolutely.
So,
fantastic.
and
Good
also
tip.
when we look at things like these, you were talking about number 2 with like cerebral palsy.
Mm-hmm.
Looking at other options, you see like number 3. If the infant isn't necessarily recognizing and smiling at faces yet, that doesn't necessarily mean there's a developmental delay or anything there. Sometimes they might need glasses. They might need something. And so, when we say that you need to be looking out to see if these things aren't happening, it doesn't mean that there's something wrong with the child at all. It simply means that these are expected for a reason, and so we want to make sure that if they're not happening, that we can determine why, whether that be that they're just taking their time, or it's something that would require some sort of intervention or follow-up. And so I'm not seeing any questions here yet.
Awesome. If there are any on this item moving forward, just let us know at the end. Happy to go over that. So we will go ahead and go on to our third item. There's one more after this, which will be a SATA, but I will go ahead and let Holly take over on this one.
All right, so y'all know I work in cardiac, so these are my little.
It's your bread and butter.
So we've got here a question that's going to be covering ECGs, electrolytes, and a little bit of prioritization.
Fantastic.
So here we've got a question. We are given a serum potassium level, and we need to determine what finding we should be monitoring for in this client. So I always like to put myself in the question. It says the nurse, but I feel like when you can put what should I be monitoring for, kind of makes it a little more of, okay, what would I really be doing in this situation?
Definitely.
And not just looking at somebody else.
Mm-hmm.
So we've got our options here. I'll let you guys use the poll: diminished deep tendon reflexes, sinus bradycardia, which would be a heart rate less than 60 on the ECG, tall peaked T waves on the ECG, or option 4, a tingling sensation around the lips. So something I try to do is to match up, especially if we're given a value. This is kind of as a tip for you guys. Especially if we're given a lab value or anything like that, I want to match up my options to that to find the correct answer. So we know here that we have a potassium level. We need to first determine, is that potassium a high or a low value? And once we get there, we can say, okay, then we can try to match our options up with that. So for example, we look at option 1, diminished deep tendon reflexes. What electrolyte does that go with? And is that a high or low value? Apply that to all 4, and you can get your answer a little more.
Very good.
So looking at our answers here, it looks like most of you are saying option 3. So we'll pick that here. Good job. So we look here, if you answered 3, you were right. And this is because we have hyperkalemia, as you can see down here. So elevated potassium. So I'm going to explain a little bit about hyperkalemia and how it causes the ECG changes before I come to this, because I think it'll help it make a little more sense. So we're just going to hide it for now. So with potassium here, we have over 98% of our bodily potassium living within intracellular fluid, especially within the muscle. So if we have even just a little change in that concentration outside of the cell, we're going to have an effect on our cardiac and neuromuscular functions. Potassium is really involved in this cardiac conduction pathway, which I'll show you again as well. This is where all the electrical impulses travel, and that is how the heart is told, time to contract, time to start diastole, time to start systole, all of that. And so when we have elevated potassium, we're going to have an alteration in that electrical signal. So something important to note here is that impaired kidney function is going to increase our risk for hyperkalemia because potassium is excreted by the kidneys. And so I want you guys to always think about when you see hyperkalemia, just try to think renal, try to think kidneys, and also think ECG changes, excuse me. So those 3 are going to kind of always go together: kidneys, hyperkalemia, or potassium, and ECGs. If you can remember that, that can definitely help you in a lot of other questions. And so when we look here, because hyperkalemia alters the electrical signal that conducts the heart, we get what are known as tall peaked T waves and also a prolonged PR interval. Those are a lot of letters. I'll give you a little bit of a rundown in a second. But what happens is, because there is too much of the potassium, the electrical signal is a little bit hindered in getting to where it needs to go. So we get what's kind of called a marching out, if you will, and I'll show you what that looks like. But what's really important when we have hyperkalemia is prompt treatment. Now, if you look here at this table, we've got a lot of different options for treatment. And depending on what it is, it's either going to remove the potassium from the body, it's going to bond with the potassium to cause it to reduce, it's going to move where the potassium is, all those things. But what is really important with the treatment is that we do not reduce the levels too quickly. Because like I said, that potassium is so concentrated intracellularly that when we cause those shifts, we're going to have conduction issues. So if we cause a shift too much the other way, we're going to cause other conduction issues. So looking at all of these, obviously hemodialysis would be one you're pretty familiar with, because that's literally just going to take it out of the blood. But also other ways like giving a diuretic. So someone is going to just urinate out a bunch of potassium. Giving calcium gluconate, because it's going to basically make the potassium less effective against the cardiac system. So obviously all these are different, and they have different, you can see this is 2 to 6 hours, this is immediate. It really depends on what is going on with your client and what the provider feels like is most appropriate.
Mm-hmm.
So like I said, we want to make sure we're treating it, because if it continues on, our P waves are going to diminish, QRS complex is going to widen, and we can eventually end up with VFib, which is our little squiggly line, VTAC, which is, not good either, but at least sometimes these clients still have a pulse, or even asystole, which is just nothing going on. So I'm going to go back up to the image here just to show you guys. I feel like this will make a little more sense now. So normally you wouldn't have quite this much space here, but what's happening is, like I said, that electrical the electrical impulse is taking a little longer to get to where it needs to go. So the heart kind of knows, because it's been doing it for a while, what it's supposed to do, but nothing's telling it to. And so we start seeing this kind of slowing. So here we've got a prolonged interval, and here we've got an extra peak, because around here is where this should start to depolarize and come back down. But that signal is taking so long to get there that it's just going to keep going up and up. So this is where we start, and this was the answer to our question. But as it progresses, this P wave kind of goes away. It ends up really somewhere over here, and that's why this is elevated. And then from there, everything, like I said, marches out, if you will, and it just kind of does a stretch. So your heart rate may not necessarily be decreasing, but the way your ECG tracing is that everything's going to kind of move out. And eventually it will slow, or VFib and VTAC, it's going to look artificially high. So as that marches out, we eventually get so marched out that we have nothing, because those electrical impulses just can't reach at all. So when we start seeing this, obviously, we want to not even have this happening, but if this is happening, we need to treat it so we don't start going this way.
Yes, absolutely.
So looking at those, I hope that makes a little more sense. So again, this is just the conduction, so it's going to go, and it's just going to essentially hit a wall. And so that's where you're going to also see when you talk about like an AV block, that kind of things. It's literally a block where it is just hitting a standstill. And so looking at those, we can also now look at our incorrect options. So options 1 and 2, we had diminished deep tendon reflexes as well as sinus bradycardia. And if you guys remember from our live a couple weeks ago, Alexis walked through a question on magnesium toxicity. And those are signs of hypermagnesemia or magnesium toxicity. If you remember that magnesium is a CNS depressant, meaning that things are going to kind of slow down and relax. And so when we've got too much magnesium, we're going to be a lot less responsive and receptive to things. You should be watching these, though, obviously not what this question was about, but if they're happening, because if their magnesium levels continue to rise, they're going to become so just relaxed and zonked out that they could have respiratory failure, they could have cardiac arrest, all that. Lastly, option 4, we had tingling around the lips, and that is caused by hypocalcemia. And so hypocalcemia causes tetany, which is going to be, your muscles are going to start contracting and contracting and contracting, and eventually they're not going to be able to stop, and they're going to be kind of stuck. So the hallmark signs of this are going to be called what's called Trousseau's sign and the Vostek sign. And so if you look at these, essentially these are like the client is not trying to make this signal or make this with their face. This is like they are stuck in this. And so if we're seeing that, obviously this could look like a stroke. We don't want to have that either. Mm-hmm. But, if the client is not able to relax or they feel stuck with it, that can be an indicator as well. Mm. And so like we said, fingertips, toes, perioral region, those are kind of where it's going to start and it can move. Important to note that it can be a chronic and asymptomatic thing if we have a client that has prolonged malnutrition because their body's just adjusted. But we also could have an acute onset. And this is an important one to notice, that when there's injury to a parathyroid gland during the thyroidectomy, we can have acute hypocalcemia. And the acute is really what is important to note because when something changes really quickly within your body, it's going to upset it a lot more than the gradual change. So, all that to say, our objective here, remember that hyperkalemia alters our electrical signal that conducts the heart, and it causes it to take a longer time to get there. So we're going to end up with tall peaked T waves and the prolonged PR interval. These are early signs. So as it worsens, the P waves will become diminished or absent and the QRS complex will widen, and that can lead to the lethal ventricular dysrhythmias such as ventricular fibrillation, tachycardia, and or even asystole. So if you guys have any questions, you can go ahead and leave them there. And again, we can get to that. We do plan to eventually do a little more with ECGs and reading and all that, but while I'm waiting on questions, I do just want to make sure you guys know the test plan does list out some of the rhythms that you need to know, and obviously we want to be able to identify them, but the biggest thing with you as new nurse and just even taking the NCLEX is we want to make sure that you can identify when something is awry, something is not correct. So even if you can't say exactly what that rhythm is, we want you to be able to go, okay, well, that looks a little funky, that looks a little different, and be able to go from there. Especially like this, being able to make that association with your electrolytes and the changes in the body, potassium, EKGs, magnesium in terms of its depressant capabilities. Being able to make those connections will help you NCLEX, but also help you just in practice to be able to kind of put those pieces together of the clinical picture and really look at it. So,
can we go back to the explanation real quick?
Yes, please.
Yeah. So I think the wonderful thing about this is we have, with this item, we have so many different, images and tables. Absolutely. And I mean, it's a great way to really take a look at and identify what's going on with potassium in the body. Mm-hmm. In fact, this is, it lays out very well kind of what happens as far as the ECG tracing goes. Now, if all we need to know, or if we are a little daunted by that and we see that we definitely need to know the tall peak T waves, then, this is what I like about this is it gives you the extra explanation that you may need to help that solidify in your head.
And I think
but if you just get it off the bat, then
absolutely. This is a great example of how, with UWorld, yes, we want to make sure you're doing well and we want you to do well, but we're really more than anything trying to help you learn and trying to teach you. And so yes, like Andrew said, you may just need to know that part for the question, but if we can help you understand the why behind it and really be able to use it to implement into other questions, then I think that we were pretty successful with it because, it's helping you more than just answer a question. It's going to help you answer other items. It's going to increase your knowledge and eventually, help you in practice. And so we just want you guys to learn. And so if we can help you do that, then we are very happy. So
absolutely.
I don't see any questions coming in. So Andrew, if you want to go ahead and move to our fourth item here.
Going to our kind of final question. All right. So while the last one was Holly's bread and butter because she's a CVICU nurse, this one is completely opposite of what my bread and butter is as far as being a med-surg nurse. This is an L&D question. You're saying, Andrew, why are you answering an L&D question?
Why?
Well, I had to know L&D, as all of us do who are looking to get our license. We had to know a basic, or at least a minimum understanding to provide safe, effective patient care for maternal newborn patients. So
it's in the test plan.
It is, well, exactly. And you're saying, well, why would you need to know this? How often do you encounter that on a med-surg floor? Not often, but I have taken care of women who are pregnant before, and I've taken care of women who are postpartum before as well. So understanding and knowing kind of these minimum requirements as far as the NCLEX is concerned all nurses are required to know that. Now, for those of you who are more L&D oriented and really like the specifics, and that's where you want to head, after you get your license, then fantastic.
Get a lot of training.
Oh, for sure. But like one of the things is any floor you go to, it doesn't matter. Even if it's something as simple as med surg, you are going to learn so much more than you thought. And a lot of it's going to be hands-on. A lot of it's going to be very, a lot of technology-oriented kind of things as well. So
I knew nothing about the heart when I got to my job. So
there you go. Yeah, I mean, your learning never stops as a nurse, and if it does, then you really are a perpetual student because there's always something new going on in the medical field. So
and as you'll see in this question too with Andrew, that your fundamentals you learn and different things. You're always going to be able to apply them. You may not know exactly what the question is wanting. And like Andrew said, what if I don't know about Kawasaki disease earlier? Same thing here. You may not know about late decelerations. But if we can at least apply principles that we've learned within fundamentals, within even med-surg, and understanding things like circulation and understanding all those really just basic how the body is functioning things, then we can at least kind of start heading in the right direction on these questions.
Absolutely. So some of you already started putting answers down for this, which is fantastic. So we have a client who's 39 weeks gestation. They're receiving IV oxytocin infusion, okay? And we have late decelerations. So clearly, stop right there, right off the bat, we're talking fetal heart rate, right? FHR. So what's the one thing you're going to be thinking of right now? It's going to be veal chop, right? So get that in your head for those of you that still haven't had a chance to answer, right? And what are you thinking? Like what late decelerations? What is causing late decelerations? What do I need to be concerned about, right? So if I know or understand or can think about what might be causing late decelerations, then I have an understanding or an idea of how to answer this question. Yeah. So
it looks like we're getting 1, 3, and 5 as our options here.
We'll go ahead and move along with this, and then of course, since we have just under 20 minutes left, we'll try and go through this so we can answer any questions at the end. So 1, 3, and 5. All right, good job, y'all. So let's talk about late decelerations really quick, and then we'll kind of get into this. Again, this is not something that I see in my normal practice on a day-to-day basis. I am still at the bedside as a med-surg nurse, but I have, as a former nursing student, I do remember reading some of these strips. So when you're talking about late decelerations, okay, you're going to see that on the strip as, here comes the contraction. We're reaching the peak, or we're getting close to the peak, or we're at the peak, and then we have the onset of the deceleration. And a deceleration is a decrease in fetal heart rate, right? So when it comes to a late deceleration, it's going to be a very gradual kind of decline until we hit the nadir, which is the lowest point of that dip, and then we're slowly going to come back up. And from the onset to the nadir is going to be about, right here it says about 30, greater than or equal to 30 seconds. So this is important to note because when it comes to something like variable decelerations, those are often abrupt, and from the onset to the nadir can be less than those 30 seconds. Also and not getting too much into variable decelerations, but also with variable decelerations, it's not necessary. It can happen anytime. Really, when
whereas
it comes
this is going to be more of a consistent.
Right, this is going to be consistently located, the onset at least close to the peak of the contraction and the nadir following, mostly following the contraction, if not the very end of it. So, late decelerations, what we're concerned about, the biggest thing, so veal chop, let's go ahead and pull that up, is going to be placental insufficiency. Essentially, there's not enough oxygen getting to the fetus due to either tonicity of the uterus, it's contracted too much, it's not allowing for enough blood flow from the uterus to the placenta, and from placenta on through the cord, the umbilical cord to the baby, to the fetus. And so we have to be concerned about how are we going to increase that perfusion? What is the thing that we need to do to increase that perfusion? So again, things that can cause that: uteral placental insufficiency, uterine tachysystole, which is when, we don't have much of a break in between these contractions, right? And so that uterus is not fully able to rest in between contractions. It's not able to allow, more oxygen-rich blood to fill that space to be able to pass on that oxygen to the fetus. So One of the things that we're going to do to help increase or improve fetal perfusion is going to be administering an IV fluid bolus, okay? That can help increase the maternal blood volume, and that will also help get that to, obviously the rest of the vital organs, which in turn will include the uterus, and will help to increase that perfusion to the placenta. Another thing, and this is probably the most important thing, is going to be discontinuing that IV oxytocin infusion. Not only can the frequency of contractions not allow for that blood flow to really take place and that oxygen-rich blood to get to the placenta, but if it's too strong, if it's maintaining that strength for too long, it can really constrict those blood vessels and really diminish the blood flow. So stopping that IV oxytocin quickly, and certainly notifying the healthcare provider that is, happened, is very important. And then another thing that should be considered is repositioning the client laterally. So what that's going to do is that's going to help relieve compression of the maternal inferior vena cava. And is that going to pull up for us? That's okay.
Taking its time.
It might need a second. Let's see. No worries. So if the mother is laying, supine, that the weight of the fetus on the vena cava can compress it and not allow for as much blood to return to the heart. And so what we want to do is you want to reposition the mom either onto the left or the right. Most L&D nurses will say the left might give a little bit more perfusion. So repositioning on the left side first will help take that pressure off the vena cava and allow for that blood to get back to the heart and to the lungs. So those are our 3 options that are correct. Let's talk about the 2 that are incorrect. So apply abdominal vibroacoustic stimulation and prepare the client for an amnio infusion. So vibroacoustic stimulation is something that can be used during a non-reactive non-stress test. It can also be used during labor, especially if you have minimal variation in the fetal heart rate, to help induce or elicit fetal acceleration, the acceleration of the heart rate. What happens is if you're going to use that, or one of the things that can happen when you use that during fetal heart rate decelerations or fetal bradycardia, sometimes it can elicit a vagal response and actually worsen the bradycardia. So that is not something that we want to do. Vibroacoustic stimulation can be something as simple as, patting or touching the mom's belly, or sometimes they have little devices that can elicit a vibration that will spur about that acceleration. So that's not something we want to do in this case, at least not right now.
And that's because our client, like you said, they're already, or the fetus is already experiencing bradycardia to some degree, and we don't want to put that stress there because if they're already continuing to decrease, we could cause a vasovagal response, we could cause different things and cause a further decrease in heart rate. And at this point, we're trying to increase our fetal heart rate and not decrease further.
Absolutely.
So we wouldn't want to do anything that would potentially cause that.
Yes, definitely. So our other option would be an amnio infusion. This is used to relieve persistent, recurrent, variable decelerations, which again, if you think about veal chop, right, that's going to be due to either cord compression or sometimes oligohydramnios, which means there's not enough fluid within the intrauterine cavity to kind of help, make that cord a little bit more buoyant and allow for a little bit more space in the uterus. So amnio infusion is not going to be indicated. It's not going to help in terms of any type of perfusion from the uterus to the placenta and then on to the fetus. So again, amnio infusion is going to be for variable decelerations related to cord compression or oligohydramnios. And so this is just a little example of what variable decelerations look like. Again, you have this like V shape that's very abrupt. Again, from onset to nadir, it's less than 30 seconds, okay? And then it's variable, right? So this one's occurring, the nadir's occurring at the peak of the contraction. This one's occurring kind of just slightly after the peak here. And again, here's another one. So that's what I have for that. Late decelerate, again, so our educational objective, late decelerations of fetal heart rate indicate compromised fetal oxygenation and perfusion. So intrauterine resuscitation interventions include administering IV fluid bolus, discontinuing that IV oxytocin infusion, which is very important because that's going to help, allow the uterus to relax, get a little bit of break in between the time of contractions, and it's not going to contract as forcefully, allowing for more blood flow, and then repositioning the client. So,
Definitely.
which is also, you can use that for cord compression, but it is definitely something you want to do for late decelerations. Yeah.
So I just want to reemphasize, I know we talked about variable decels and the late decels themselves. So, just remembering students, when you're looking at, if you're looking at heart tracings or any of those, that the variable decels can have an onset like whenever, it doesn't matter. But if we are having late decelerations, it's always going to be after the peak of the contraction. And that is not when it should be happening. They should be having that, kind of lining up with one another on your tracing. Almost I guess an inverse would be a good way to show it, there'll be, one is going to be peaking up while the other is peaking down, and that should be at the same time. So when we have the late decels, we're going to be having that contraction, having its peak, and then the deceleration is going to come after. And that is the abnormal, is that it is not happening when it should be happening, or when it's normally expected to be happening.
And so you're at that peak, right? And that's a peak contraction. The oxygen is not getting to the fetus, and so what's happening is the cells within the fetus are starting to elicit a chemical response in reaction to that low oxygen concentration. So it's going to lower that heart rate, is what you're seeing with that bradycardia, and that's why it's occurring, or why the low point of that heart rate is occurring after the contraction.
And I do want to point out, I know some people I see were mentioning something about oxygen here. Just know that at one point was a big teaching point, was applying oxygen, but that is not considered with late decelerations. One of the indications, your textbooks are not even going to have that anymore. It's really only going to be indicated if we've got a hypotension situation with the mother, or it's more like if there's an issue going on with the mother, or with the client who's actually laboring, rather than the fetus itself.
Right. So if you're looking at the mother and their oxygenation is low, or below 92% or whatever, they're having trouble, they're tachypnic, they're having respiratory problems. Obviously, yes, you're going to be giving them oxygen. So
you may still be seeing some older sources that would mention applying oxygen with late decelerations, and just so you know, that was the teaching. But as everything is always evolving and changing, as we learn more about what's going on inside the body and inside, laboring, we've got a lot of things going on there. And so, as we've researched more and learned more, we've learned that is not necessarily an indication, or late decelerations are not necessarily an indication, and that it needs to be, oxygen is only really the indication if it is a concern with the mother in terms of her perfusion, her oxygenation, all that. Her, not the fetus. So.
Definitely. Yep. And if you're using an older textbook, some of those things may not be updated yet, but just something to keep an eye out and something to be aware of.
We try to stay nice and current here, so here you go.
Yeah. Any questions at all? That's our last item. Are there any questions at all that you all have? Anything about UWorld or any of the topics that we've covered? We really did try and make sure that we had kind of a broad scope, especially of things that we hadn't really covered. A couple of pediatric questions, L&D. Usually people really like those. So as far as test-taking tips and strategies, I know we've already covered a good portion of that.
I think we could kind of hit some more with the SATA on here.
Yeah, definitely.
I know we had, we talked about reading from the bottom up, and then we talked about the true or false statement. Something I've mentioned too is, when we're in an option here, I want to make sure that we are looking at kind of the subject or the teaching point of each answer choice. So I'm going to go to, wrong one. Back to the question we were in. And so somewhat of what we were talking about earlier, with, why would we be doing certain things? And so when we're looking at repositioning the client, what is the teaching point here? Why, or what would repositioning do? And, it specifies laterally. So what would a lateral position be doing? Because sometimes, there could be an answer that's repositioned, but it's an incorrect reposition. And so we want to make sure we're looking at the whole thing and seeing what is the teaching point here. We know, because this is the correct answer, that repositioning them laterally is going to reduce the pressure on the mother's vena cava, and so we're going to increase blood flow. And so that's the teaching point we can identify here. You know, on 4, we can identify the teaching point, but we know that it is not a teaching point that relates to late decelerations. So we can cross that one out. And so applying that principle as well. Also, always be looking for opposing options. If you've got 2 choices that are opposite of one another, it can't be both of them. Sometimes it's going to be neither. Sometimes it would be just one. But it can't be both if they're completely opposite answers, because that just doesn't make sense. And then my last one is look out for options that kind of, I guess, depend on other options to be correct. So, you know, sometimes you may see something that on its own you wouldn't do, and then another option on its own you wouldn't do. But if they're both there together, they could both be indicated. So, you know, make sure that if you have things that you need to pick that are together and required, that you do all of those. But you know, just be looking for trends in that. And I always say look out for, especially in your question stem, the idea of when we see words like only or never or always. We call those qualifiers here. And so look out for those, because those are going to be a big indication. You know, if it is something that says always, never, or even if it's in an option choice, that's kind of making a bold statement. And it doesn't necessarily make it right or wrong, but it needs to be something that you pause and look at. Because if it says, you know, always do this or never do this, you know, there's certain things that there's going to be an always and a never with, and those are like important to know. But, you know, a great distractor option would be to flipping it on its head and, you know, put always do something that you should never do. And so just see those words and kind of use those as a caution, and, you know, stop, look back, and really read through. And like we talked about too earlier, you know, even if you were like, I have no clue, oxytocin, labor, 39 weeks, just stop. And like Andrew said, if you can at least remember veal chop here, we can say, okay, we've got veal and we've got chop. And we know that with late, it is placental insufficiency. And in my med-surg fundamentals, all the things I've learned, I know that that means we are not getting blood flow, we are not perfusing. So which of these options are going to help us get there?
Absolutely.
Obviously, there's a lot more going into it, but for the basics of the question, we can get to that.
Yeah, definitely.
So I'll give you that mic. We're going to look at some of the questions you guys have for us just to see.
Yeah, just briefly. It looks like I think some of our moderators were answering a question on select all that applies in NGN. Just to reiterate on that for those of you that are curious, so NGN items, the scoring will be slightly different than current select all that applies. For those of you not taking the NCLEX exam until, the NCLEX until after April of 2023, you don't necessarily have to worry about that type of scoring. Current select all that applies, you either get the question correct or you get it incorrect. When it comes to computer adaptive testing, CAT, as far as, you know, whether it's going to give you a harder or easier question following that, there is a minimum baseline level that you will have to meet, competency-wise. So it really just kind of depends on where you're at in the exam as far as whatever questions you've answered. So if you can't, one of the hard things is you want to know if you got a question right as soon as you answered it. And that's kind of the nice thing about UWorld is you can get in, you can see, you know, if you've answered it correctly or not. Really the big thing is take a deep breath, answer the question, and then move forward. You know, it's try not to dwell on that item. If again, whether you get it right or wrong, you're not even going to be able to know. The test will adapt itself based on what you have answered correctly or incorrectly.
Just a word of advice. I know I did this during my exam, and I wish I would not have, but there's always been a rumor that, you know, if you've got more select all that apply, you're doing better or worse or whatever. And I was like trying to count all of them, do all that. Don't worry about it. The computer is simply trying to figure out if you are above or below the passing standard.
That's right.
So it's going to ask you questions to try to figure that out. And something important to note with the select all to apply, when the next generation NCLEX launches on April 1st of 2023, you're still going to have regular select all to apply, regular multiple choice. Those are still going to be there. And so it's still going to be some select all to apply that you have to get all of them right to get the question right. But there are also going to be some options or some items that have up to 8 options. And with those, it's not going to be you have to get all of them. You can get partial credit on those that have extra options. And so you'll start seeing those and how they play out. If you're interested in any of it, the NCSPN, which is who creates the NCLEX, on their website has a whole wealth of resources and newsletters and different things that really go through the nitty-gritty of what these new items look like, how they're scored, what they're designed to do and teach, and kind of how they'll pop up, as well as the breakdown of what your exam is going to look like after April 1st. Because it's not going to be, every question is next generation. There's still going to be a lot of regular things, and I think that's a misconception too, is that everything's going to be totally different. And so if you can understand how much of it's going to be what you're used to and how much of it's different, that can really help you. And then of course, practicing items like we have with case studies, and when we start having other of the what we call standalone, so just single items that are next generation, that can help you get to the exam and be like, oh, I've done this before.
Ready to go. Yep. All right. Let's see. I don't think we have any other questions. I think we've answered everything
Got a couple
to the best
more.
of our ability. Do you see one?
Yeah, and I'm seeing over here, it looks like with NGN, some of the different scoring is going to be applied to all the select all that apply. So make sure you look out for that. It may actually end up being that all of them are the different scoring. So
apologies.
We're all learning here, so thank you.
I know, right? It's the whole process.
A lot more things.
But again, changes and all of that are effective or will be effective April 1st of 2023. So, information is up, coming to everyone and being up to date and, curious about that. Just look out for, new information when it comes to next gen.
Definitely.
But yeah, so. Yeah,
and if you guys ever see something written as next gen, NGN, any of those, that is the short phrase for next generation NCLEX, so don't be confused. If you hear it shorthand or see it written shorthand, it's just, an easier way to get it all down quickly. I did see one other question, someone asking, when options are similar, how do we choose between them? And so
it really depends on the question.
I have a little bit, but if you want,
no, go ahead. If you,
I would say my biggest on this one, and obviously if they're similar, they're going to be close, but try really hard to identify what is different between those two. Because obviously you're not going to have the same answer choice for option 1 and option 2. So really try to narrow in on what the difference is in that. So if it is a dose that's different, if it is a medication that's different, or with a teaching point, if it's a different part of it, really try to hone in on what the two differences are there, and then apply what you know about the condition, disease, whatever is being asked about. Try to apply that to those options. And so that's what I try to do, is really just break each one down. And sometimes there are similar things, and I've been there where it's like, I don't know, they all seem good to me. And so
yeah, definitely. And sometimes you'll have names that are similar, start with the same letter as far as like medications. Maybe the disease, maybe it's just giving you a disease process, and like you have to figure that out. Like especially when it comes to disease processes that are both endocrine related or both cardiovascular related or what have you.
Systems,
right. Having that understanding of that pathophysiology and that anatomy and how that all interconnects and what that kind of big topic is really going to help. And I mean, again, to just attest to what we focus on here at UWorld is what you had talked about earlier, was we really focus on the learning aspect of it. So even with a question like our potassium item, where all you really needed to know was about tall peaked T waves to answer it, we're telling you why, we're telling you, what that's going to look like as far as an ECG tracing, what that looks like in the heart. So really getting that nitty gritty in so that you understand. And so when you do get an item where you have similar answer choices, you can be like, oh, well, I understand this disease process because of this, and I know this medication might affect it, and so I got to be really cautious about this. So. And
in the same way, we're always going to try to pick really good incorrect options, as we call them, distractors, because we want there to be a teaching value in all of it.
Definitely.
And so we can do that. I did want to remind you guys, we're getting some more NGN questions, and so just a general reminder, and then I will answer the one I see here. We will sometime this fall be doing another live series over NGN, and so we're going to try to give you just obviously going through items, but just all sorts of information on how to approach the questions. We'll probably give you a little on like the scoring and different things, and just really to help you get familiar with that layout, so when it comes time for you to actually take your NCLEX, you're not not as stressed, not as confused, because you've seen a lot of it before.
You've seen it, yeah. And it'll be a fairly similar format, we believe, as far as what we've currently been doing with these live study sessions. But we plan on doing a series over next gen. That way, you'll have somebody that can talk to you, answer questions, kind of about how the case studies and standalone options and things like that work out. So,
we did get somebody asking. So yes, there still will be standard multiple choice questions in NGN. Like I said, it's not going to be the entire test is going to be all these new items. It's only going to be a part of it. So you'll still have some of these standard, you get to pick one option out of the 4. And then also somebody's asking, apart from SATA, are there any other things that are changing with that? And so yes, when this video is posted, if you want to go back and peek at that case study, or if you go to the UWorld website and navigate over to the NCLEX-RN portion, you can see the demo. We've got the case studies. And then there's some other different item types that are more like a drag and drop or fill in the blank style, different things that, we're still just testing knowledge, but they're different ways rather than just a standard multiple choice question to get there. So again, all of that, NCSBN, who creates the NCLEX, they have these things available on their website. And just a lot of information there. If you dig, you'd be surprised how much is there. I know as a student, I didn't know about any of that, and I was like, test plan, website, what is all this? And so if we can help you guys get to that now, that's awesome.
Yeah, for sure. And there's quite a bit with Next Gen. It's really teaching a lot of the nursing process, and very much, especially with that item that we showed in the demo, it has nurses' notes, it has laboratory values, it has things that you're naturally going to see in practice, and it might even feel more comfortable to some of you when it comes to like a clinical setting, because you're actually looking at a patient's data, looking at information, and trying to ascertain what's going on, what am I going to do? Okay, these are the interventions I've done, and then, how am I going to follow up after I perform that?
It really goes through that whole nursing process, which is awesome.
Very good. Yeah.
Well, that looks like the last of our questions and all we had time for, so it works out really well.
Yeah.
But like I said, please be following us on our social media platforms so you can keep up with us and know when we will have that series or anything else coming out to you guys. It'll be really fun to bring. Kind of sad. This is our last one. I've had a great time.
It's been really fun.
6 weeks of doing this, and I feel like it's been fun to teach you guys and fun to actually get interaction with students and things and hearing back from you guys and getting your feedback. And I hope you all have seen that, we've tried to implement what you guys were looking for as the weeks went on, and hopefully we just keep doing more of that in the fall. So
so again, this fall, Next Gen Items live series here on the UWorld Nursing YouTube page.
And don't forget, if your test is coming up soon, we've got those 30, 60, 90-day subscriptions for short term. We also have all the way up to 2-year term on UWorld, and we do renewals, all those things. So if you want to have it for all of nursing school, which I think is a great idea, you guys can do that, and we'd love to answer any questions you have on our socials or anywhere else you can find us. So other than that, I think that's it. So I guess for the last time for the summer, at least.
Yep.
Well, we'll see you guys next time, but until then, happy studying. Bye.